Dr. Taft serves as a principal investigator on several funded grants, focusing on understanding and preventing partner violence. Dr. Taft was the 2006, and I'm going to botch this up, Chaim Danelli, is that about right? Young Professional Award winner from the International Society for Traumatic Stress Studies, and the 2009 Linda Salzman Memorial Intimate Partner Violence Researcher Award winner. He serves on several editorial boards of journals in the area of clinical psychology, trauma, and the family. And for such a person in demand and so busy, we're so grateful that Dr. Taft agreed to come and present to us. And so here he is.
Thank you. Can you all hear me okay? Okay. So what I'm going to talk about today is trauma-informed IPV intervention. My work, my research and clinical work is in the area of developing and evaluating programs to prevent and end intimate partner violence. I primarily worked in the area of military veterans, and I'll talk about our programs that we've developed for military veterans, but I'm going to apply all of this to civilians, and we're now kind of broadening our work to bringing it to the civilian community as well. Trauma-informed intervention, as you all know, is really it's incorporated into almost every other field of study, field of clinical work, but in the area of IPV intervention, I think it's been a little bit slow to kind of be integrated into this work. So I'm going to talk a little bit about trauma, how it's relevant for IPV perpetration, and how we go about working to prevent and end that intimate partner violence through a trauma-informed perspective. And I should say right off the bat, sometimes there's this notion that when you're doing trauma-informed work with those who are engaging in IPV, that somehow you're excusing the abuse, or you're saying that all violence is caused by PTSD or caused by trauma. And I just want to throw it out there right at the beginning. That's not what trauma-informed work means for us. When we talk about trauma-informed work, we're not saying that PTSD is the cause of violence. We're still emphasizing personal responsibility. Everybody's responsible for their own abuse. There's lots of folks who have trauma and PTSD who don't engage in abuse, and we're all responsible for our behavior. But what we find is when you give a space for folks who are engaging in violence to talk about their trauma, to tell their stories, what we find is they're more likely to join with us and take responsibility and work to ending their abusive behavior. So our work really follows from what we call a trauma-informed social information processing model. And social information processing models really sort of undergird almost all cognitive behavioral therapies. And the main idea behind this is that we process information in our social world through a series of stages. And there's a lot of research in the domestic violence area, in civilians and now in veterans, showing that people who engage in intimate partner violence exhibit deficits at different stages of this information processing, or how they're interpreting and interpreting and managing their social world and processing information. So the first phase of social information processing is the decoding stage. And this is the stage where we try to interpret the situation. We try to interpret other people's intentions. And there's a fair amount of evidence that people who engage in intimate partner violence exhibit pretty major deficits in the decoding stage. So for example, those who engage in partner violence are much more likely to assume the worst in other people. They're more likely to assume that others have negative intentions. They're more likely to assume that their partner is trying to push their buttons, or their partner is out to get them in some way, or their partner is cheating on them, or whatever else it is. So they interpret situations in an overly hostile and an overly negative way. And I'm going to talk in a minute where trauma comes into play here. Then there is the decision skills stage, where those who use partner violence tend to have difficulty generating a variety of nonviolent responses. And those who use partner violence also lack the skills to enact a competent response. So this is the enactment stage. And as I'll be talking about, there's all kinds of factors that can influence this social information processing, how we're interpreting and processing these different situations, and all of them can increase risk for partner violence. So again, notice I'm talking about increased risk, and I'm not talking about causing violence, is none of these things cause violence, but they do increase risk, and we really have to talk about them if we're going to work in a trauma-informed perspective. So there's other models out there that are consistent with this social information processing model. Some of you may be familiar with the survival mode model. And this is a model that's primarily been developed in the context of military veterans and service members, although it also applies to civilians. The general idea here, as it applies to military veterans and service members, is that when somebody is in a dangerous area or in a war zone, they need to be constantly alert, constantly vigilant to any potential threats in their environment. And while they're deployed, while they're experiencing danger, this kind of survival mode way of functioning, where they go into survival mode, they're really trying to interpret whether somebody represents a threat to them, and they're really seeking out threat and seeing threat where other people don't. So they'll be noticing people's facial expressions, trying to determine if that person may be hostile to them in some way. And they're going to be more likely to err on the side of assuming the worst, because that's what keeps them alive and that's what helps them achieve their mission, etc. The problem with this is while this is adaptive in a war zone, it's adaptive in a dangerous area, it's adaptive when you're exposed to a lot of trauma, it's no longer adaptive when the service member returns home. And they still go into survival mode. And they still assume the worst in other people. And they're still seeking out threat and assuming other people represent a threat to them rather than assuming the best. And rather than assuming, well, this person probably doesn't mean any harm or this person isn't any kind of threat to me. Unfortunately, when this happens, it often generalizes. So it carries over into all relationships. And it also carries over into intimate relationships, where again, the veteran may assume their partner has negative intentions towards them, assume their partner is trying to push their buttons, or is doing something harmful to them. And again, this doesn't only apply to military veterans, this also happens with civilians. Whenever I give talks and there's folks who work within the criminal justice system, and I talk about this survival mode, they will often talk to me about how folks in the criminal justice system describe something very similar. When folks are living in a dangerous area, when they're exposed to a lot of violence and trauma, they feel like they constantly need to be on guard and on edge, and they're seeking out threat, and they're going to respond to those threats with aggression before that person aggresses towards them. So this is something that happens in service members and also happens in civilians. So the person is more likely to perceive unrealistic threats, exhibit a hostile appraisal of events, overvalue aggressive responses to the threat, and exhibit a lower threshold for responding to that threat. So this is the general framework through which we operate when we developed our trauma-informed IPV prevention interventions. And there are a number of other risk factors that we all know are risk factors for partner violence that also impact on this kind of survival mode ways of thinking, these social information processing deficits. And I'm only going to touch on some of them here today, some of the biggies that have been shown time and time again to be important risk factors for partner violence in veterans and civilians. So PTSD, depression, alcohol use problems, and traumatic brain injury. First, regarding PTSD. So there's a lot of research on PTSD and how it increases risk for intimate partner violence. We published a meta-analysis summarizing all of the studies on this about six years ago and found pretty strong relationships between PTSD and the perpetration of both psychological and physical violence. We also found this relationship holds among both civilians and veterans, and both men and women. Although what's interesting is this relationship is a bit stronger in veterans than civilians, and it is a bit stronger in men than in women. And there's all kinds of reasons why that might be. Some argue that the gender difference might be because when men experience trauma, they're more likely to exhibit externalizing problems where they externalize their trauma reactions and are more aggressive towards others, where women may be more likely to have internalizing problems, maybe more likely to get depressed rather than be aggressive. Although these relationships still hold across all of these groups. It's just the magnitude of the relationship changes a little bit depending on what group you're looking at. What's really interesting in the context of looking at military veterans is that service members without PTSD are not any more violent than civilians. And I think this is important to point out because a lot of people ask me when I give talks about veterans, they say, how do we know that folks who are drawn to the military just aren't more violent to begin with? How do we know that violent folks just aren't more likely to join the military? And what the data seem to show is that trauma and PTSD really is driving that risk for partner violence. So when you take PTSD out of the equation, veterans look very much like civilians in terms of their risk for violence. So when one has PTSD, their risk for violence is almost 3 times the risk if they don't have PTSD. And in order to understand why is PTSD so strongly related to violence, it could be helpful to think about the symptoms of PTSD. So we've done some research where we've disaggregated the symptom groupings of PTSD to see which of the symptom groupings are most highly correlated with partner violence. And what we find is that re-experiencing generally isn't that strongly related to partner violence. So things like having nightmares or flashbacks or intrusive thoughts aren't very strongly associated with violence. Avoidance and numbing is not really strongly correlated with violence either. Now we know that when one experiences emotional numbing, when they have difficulty experiencing and expressing their feelings, that does have a negative impact on relationships. That's really devastating for relationships and is a really strong risk factor for divorce and marital problems and marital unhappiness, but it doesn't seem to predict the violence in the individuals. What is most strongly correlated with partner violence among the PTSD symptom groupings are the hyperarousal symptoms. So these are symptoms that reflect an overactive fight or flight response. Hypervigilance, consistent with this survival mode model that I've been talking about, when you kind of are seeking out threat in your environment, when your thoughts are racing, when your fight or flight response is kicking in, your thoughts are not going to race in a positive direction where you're assuming the best in everybody. Your thoughts are going to race in a negative direction where you're seeking out threat and you're kind of confirming threat when it might not truly be a threatening situation or a threatening person. So the hyperarousal symptoms, time and time again, seem to be most strongly correlated with intimate partner violence. This is a slide that I don't usually present because there's just way too many arrows and people just look dazed and confused when they look at this slide. But we circled what are the most relevant relationships here, and this is a structural equation modeling analysis. The important point from this is a paper we published in 2008. Is that this was a civilian sample of domestic violence perpetrators in a study that Amy Holdsworth Monroe did many years ago. And we looked at PTSD in her sample and found that consistent with this model that I've been talking about so far, the social information processing model, PTSD did seem to be predictive of social information processing deficits, which in turn was related to the perpetration of both physical and psychological abuse. So this is just to say that there is some evidence in civilians that these relationships that I'm talking about are upheld out there in the literature, looking at the etiology of partner violence. We've also done some research in military veterans at the VA where I work, where we really wanted to test this idea that trauma and PTSD were associated with these negative thought patterns, and that these negative thought patterns in turn were correlated with violent behavior outside of the lab. So we used a lab paradigm called the articulated thoughts and simulated situations. And this is a paradigm that time and time again has showed that negative thought patterns in the lab are correlated with intimate partner violence. And this has been shown time and time again in civilian samples of undergraduates. So we wanted to look at this in a sample of military veterans. And how this works is you have the person come into the lab, you give them headphones, and you play different relationship scenarios that are intended to provoke anger. So for example, one of the scenarios involves overhearing a partner having a phone call with a friend of hers where she's saying derogatory things about him on the phone. And what you do is you ask the person to verbalize out loud what their thoughts are, and there's a coding scheme to categorize these thoughts into different kind of thought patterns, some of them reflecting these kind of negative social information processing patterns, such as hostile attributions. And consistent with the literature, what we found was that these negative thought patterns were correlated with physical violence outside of the lab. So the more that one interpreted situations in an overly negative, overly hostile way, the more domestic violence they engaged in outside of the lab setting. And we also found that PTSD was correlated with these negative ways of thinking. So again, consistent with this model, PTSD is related to these negative thought patterns, which seem to be correlated with intimate partner violence. So just touching on some of the other risk factors, we know that most people who we work with don't just come to see us with problems with PTSD or with just one problem. Often if they have problems with trauma or problems with PTSD, they have other comorbid issues such as depression. And we know that when one has depression on top of their PTSD, their risk for violence multiplies. So it's not additive, it's a multiplicative risk for violence when you add depression onto the equation. There's some theories out there that talk about why depression seems to be so strongly related to violence. Berkowitz, who's a well-known aggression theorist, talked about a cognitive neo-associationistic model of aggression, where he talked about how the experience of negative emotion tends to be connected with anger networks. So the more one experiences depressive affect or negative emotion, the more they experience anger-related thoughts and feelings, physiological reactions. So those who are depressed are more likely to have their anger-related kind of schemas or thought processes kind of engaged. So that may be one reason why depression seems to be strongly related to violence. There's other models for violence that look at different types of risk factors. So there's another model called the I-cubed model of aggression. And what they talk about is how there's certain risk factors that increase risk in general, like PTSD is one of those. However, that risk might not actually lead to the aggressive behavior unless there's a disinhibiting risk factor on top of that. So just having PTSD may not necessarily lead to violence in a particular individual, but it's not until they develop problems such as with alcohol or substance use or a traumatic brain injury that violence is disinhibited and that behavior actually is expressed. And alcohol use is a really strong disinhibiting risk factor. We know that trauma and PTSD is related to alcohol use. Folks will drink to try to kind of damp down their PTSD symptoms, try to kind of get their traumatic memories out of their minds through self-medication. We also know that alcohol use affects social information processing or executive functioning or whatever it is we want to call it. Then there's traumatic brain injury, which is also associated with executive functioning deficits and difficulties inhibiting aggressive behavior. There hasn't been a whole lot of research on TBI in those who are engaging in intimate partner violence. But the research that's out there suggests very high rates of brain injury among folks who are in your community batterer programs. About half of all the men who are in batterer programs have some kind of history of traumatic brain injury, so extremely high rates of TBI. This is especially concerning with military populations because we know that about 20% of returning veterans are screened positive for some traumatic brain injury during their service. So this is a serious issue in returning veterans and in folks who are engaging in violence in general. It seems to be a pretty strong risk factor for partner violence. Now next I want to talk about some other risk factors for violence and some other kind of core themes that may underlie aggressive behavior and relationship problems that aren't really talked about as much as these psychiatric risk factors or these physiological risk factors that I just talked about. When most people think of risk for violence, they go right to PTSD or depression or brain injury or alcohol use, and they often think about different diagnoses. But what we know is that actually most people who come back from a deployment, most people who experience trauma in the civilian world actually don't develop PTSD. However, just about everybody who experiences severe trauma, if you ask them if it changed the way they view the world in different ways, they'll almost all tell you that it has, right? So it's really helpful to not only think about risk for violence and risk factors in terms of psychiatric disorders or brain injury or substance use, but also just to think about how does the way we view the world change after we're exposed to traumatic events. When we developed our programs for partner violence, we worked closely with Dr. Patricia Rezick, who developed cognitive processing therapy. And in her PTSD treatment, she emphasized a handful of core themes that she really thought were really important for understanding trauma reactions and PTSD reactions in folks who were exposed to severe trauma. And similarly, in our program, we have kind of taken the work that Dr. Rezick has done and have brought it into our work with those who are engaging in partner violence. Because similarly, we believe that these various core themes underlie relationship problems for a lot of the folks that we work with and are really important for understanding and intervening when we're trying to prevent and end the violence. So I'm going to talk about a handful of these. Of course, there's many more relevant core themes for partner violence, but I think these are the ones that come up again and again in our work. I'll talk a little bit about trust, self-esteem, power and control, conflicts, and guilt and shame. So first, let's talk a little bit about trust. When we're running our program for those who are engaging in partner violence with military veterans, often when we talk about trust, we'll ask the folks in our group, how many of you have difficulty trusting other people? And I think just about every single time I can remember, I can't remember there was a time where not every single person in that room did not raise their hand. Everybody raises their hand when we ask them this question. How many of you have difficulty trusting other people? And that is because of trauma that they've experienced. When you witness folks doing bad things to each other, when you see people engaging in violence towards each other, when you feel like somebody has betrayed your trust in some way, has put you in harm's way in some way, or didn't have your back, or let you down, or whatever it is, it's going to be a little bit harder for you to trust other people. And when we're talking in the context of severe trauma, it could be extremely difficult to trust other people. The trauma may have been caused by someone who was supposed to be trustworthy. Others may have made poor decisions or mistakes. And sometimes what happens is these feelings of mistrust generalize from the specific person who let them down to everybody. And often those feelings of mistrust carry over to intimate relationship partners as well. And of course, we know that when we have trouble trusting our partners, that's when the abusive behavior begins, and that's when the controlling behavior starts. If you don't trust your partner, if you think your partner is going to do harm to you, you're going to start to assume the worst in your partner's intentions and then engage in more abusive behavior. Or if you assume your partner is cheating on you, that's when the controlling and abusive behavior is more likely to start and escalate. Self-esteem is another core theme that's very relevant for the folks that we work with in our program. Many of the folks we work with unfairly blame themselves for trauma that they've experienced. Many of them really do blame themselves. Many of them have low self-esteem because after their trauma-related experiences, they may be experiencing other problems that make it difficult for them to find work or to function out there in the world in relationships or academic settings or whatever it is. So self-esteem is often low in folks who experience trauma. We also know that low self-esteem contributes to relationship abuse, or contributes to risk for relationship abuse, because the lower one's self-esteem, often what happens is they start to think to themselves, well, why is my partner with me? Or she or he is going to leave me because they're going to find out what a loser or what a failure I am. And then they're going to do more of the controlling, coercive kinds of things. Power conflicts, so power and control issues. And Dr. Stiff talked a little bit about this in her talk, how she doesn't believe that power and control conflicts are really at the core of everybody's relationship abuse. And I agree with that. I think there's various core themes, and some of them are more relevant for others. And part of the work that we need to do is to better understand what are the core themes that are most relevant for this particular person, and it's really different for everybody. Now, we do know that we live in a patriarchal society, and power and control conflicts are really important to consider regardless of who we're working with. But it may not necessarily be equally relevant for each person that we're working with. What we do know is that when people experience severe trauma, often they feel completely powerless, they feel completely helpless. They feel like there's nothing they could do about their situation. And sometimes when folks are exposed to trauma, after their traumatic experience, they try to kind of regain some kind of control and power in their lives by controlling other people and controlling everybody in their world, including their family members, their relationship problems, and their kids. In the military context, another thing that happens is when service members are deployed, often their partners take on more responsibilities and roles within the household. Then the service member comes back and wants to regain control over everything in the house, and their partner is not necessarily ready to relinquish their control over these different things at home, and often these power struggles can really escalate and lead to more severe abusive behavior. So we know power and control is important. Many of the programs out there in the community are primarily emphasize power and control as the primary, I guess, kind of ideological mechanism for intimate partner violence. Shame is also very relevant in the trauma-informed work that we do. Many folks that we work with may experience shame for the trauma they've experienced, for abuse that they've experienced. They feel guilt and shame for their own victimization. Some have argued that aggression may represent a maladaptive effort to cope with this shame. So rather than experiencing shame and the associated feelings that go along with that shame, they kind of project those feelings outward onto other people, and it comes out as aggressive behavior or abusive behavior. So folks who experience shame often are not really honestly and directly processing their shame and working through it, but rather they're misdirecting it towards others, and it comes out as aggressive behavior. Shame really hinders responsibility taking. So in our trauma-informed work with those who are engaging in violence, we really do try to get folks to talk about their feelings of guilt and shame. Oftentimes when we have a group member who will be kind of minimizing or denying their abuse, we'll ask them kind of straight out, what makes it hard for you to talk about abuse that you've engaged in? What makes it hard for you to talk about what you've done to your partner? And hopefully what we hear from the individual is that they'll say, well, I actually feel really bad. It's really hard for me to talk about because I feel really guilty or I feel shame for what I did. And if you can get folks to openly talk about their guilt and shame for abusive behavior they engaged in, oftentimes you're removing a really major barrier to them taking responsibility for their abuse. So getting them to talk about shame can be really important for motivating them and to help them to join with you in recognizing that their abuse is a problem that they need to change. Okay. So that is my spiel for etiology of partner violence and understanding risk factors for partner violence. Now I'm going to shift gears a little bit and talk more about partner violence intervention. The reason that we started developing these programs for partner violence, about 10 years ago, we developed programs called the Strength at Home programs in the military context, is because there really wasn't a lot of data out there showing that partner violence programs were especially effective. So there is a review study done actually many years ago now showing that those receiving IPV intervention averaged only a 5% reduction in recidivism relative to untreated groups. In the military context where we're doing our work, the research has been even less kind of conclusive to show that anything really works. And when we're talking about what's effective, I think it's really important that we're talking about randomized control trials. Because there's a lot of programs out there and a lot of folks who are promoting programs out there who will tell you that their program is evidence-based. But if they haven't done a randomized control trial, it's really hard to say that their program is really effective. Just because for any problem, anything that we're studying, anything that we want to show that it works, you have to show that it works better than something else or people who are in another condition. Because people who are, for example, in the intimate partner violence world, people who are referred from the courts to a batterer program in the community, many or even most of them are going to end their violence just because they got arrested and just because they're afraid of going to jail or just because they're being monitored by a probation officer or because their partner took out a protective order. There's all kinds of reasons why somebody will end their abuse. So you're going to see reductions in their abuse. So for that to be meaningful, what you have to know is, are these reductions in their abuse in one program greater than reductions in abuse in a comparative condition with similar individuals just undergoing different procedures? So that's why randomized controlled trials are really important. And in this area of intervention, there really haven't been very many randomized controlled trials showing that anything works, especially in the military context. Now, of course, and I'm not saying this to bash other researchers. There's a lot of great folks who are doing this work, but this is really hard work to do, right? It's really hard to randomize people engaging in domestic violence to a no treatment control group. It's really hard to get that through an IRB. There's all kinds of problems and issues. There's all kinds of barriers. There's the issue that I just talked about, how there's so many other factors that can lead to an end to the violence, such as court involvement, protective order, lack of contact with the survivor. There's so many factors that can lead to a reduction or an end in the violence that to show that something works, you have to show it works above and beyond all of these other things. So this is really hard to do. It's a lot harder to do a clinical trial for looking at preventing intimate partner violence than it is, for example, reducing PTSD or depression or other disorders that don't have all of these other interventions going on at the same time. Also, just some limitations of existing interventions, and I should say right off the bat, I'm not talking about all interventions. I'm talking about kind of many interventions, just kind of in general, many or most interventions. Most interventions out there really vary in terms of the degree to which they are trauma-informed. Many programs recognize the need to be trauma-informed, and they may involve some training in trauma and PTSD, but it's not necessarily built into the program to really make sure that folks who are doing the program are doing it from a trauma-informed perspective. And what often happens is you get different providers who are implementing the program differently, where some who have a more trauma-informed mindset will implement it in a more alliance-enhancing kind of way, a more motivational way, and others who really don't have that background in trauma may be delivering the program in a more confrontational way. So many of the programs are not necessarily trauma-informed. Some de-emphasize psychiatric factors such as PTSD and the core themes that I was talking about. Some practice guidelines also really de-emphasize many of these factors. Many programs out there in the community are not really considered therapy. They're mostly considered psychoeducation. And in our program is a little bit different, that we really do consider what we do to be really intense therapy, intense trauma-informed therapy. And we think that's really what's needed when you're working with folks who have such extensive and severe trauma histories, to really go in depth into their trauma, to have them really think more about where their violence and abuse is coming from if you want to try to change some of these patterns and some of these core themes. Often in the community, the groups are large, often impersonal, 10 or 20 folks in a group. Our groups are much smaller. Often we have only 3 to 5 folks in our group, which I think is really helpful, because in our group, you can't get anybody who's going through a whole session without talking about their situation, without digging a little bit deeper and talking about their own experiences and what's going on with them, because the other guys in the group would never allow that to happen. So you can't just go through our program without really talking about your situation in depth. And also, many of the programs often don't emphasize prevention. And so I'm going to talk a little bit about the importance of prevention and how we also try to work at the level of preventing the violence before it begins in the first place. Because we know that violence is a lot harder to end once it's already begun. Okay, so next I'm going to talk about the Strength at Home program, which is the name of the program that myself and my colleagues developed. There's actually 2 different Strength at Home programs, like I just alluded to. There's one program that works with perpetrators, those who are engaging in violence. We've been doing this work for about 10 years, working primarily with military veterans, although now we're also doing this program in the community with civilians. We have another program that's focused on preventing the violence before it begins. And this is work we've been doing with military couples after a deployment, where we're working with them to, in a trauma-informed way, to recognize negative patterns in their relationship, provide them skills, relationship skills, and to prevent violence before it begins in the first place. So first, I'm going to talk about our perpetrator program. This was a program that was initially funded through the Department of Defense and the VA, as well as through some funding from NIH. The idea behind Strength at Home was to develop a model program, an evidence program for treating IPV in service members and veterans. Because while there's a lot of programs out there, again, really none of them have been shown to be effective via randomized control trial. No other kind of group program has been shown to be effective. So we recognize the need, rather than just kind of throwing out various programs, which is often what happens in the military context. If there's an emergent need for a problem, we just kind of throw a program out there without really evaluating it. We wanted to do this in a really planful way and evaluate how effective the program was before we start implementing it on a wider scale. And as I'll be talking about, so we did the clinical trial, and now we're actually in the implementation phase where we're implementing the program across the country. So this is a program for those who've engaged in recent partner violence. They are closed groups, meaning everybody starts and ends at the same time. This is, again, something that's a little bit different than what's often done in the community, which often tend to be kind of rolling admission, where folks can come in at any time. The reason why we think it's really important to do closed groups with a trauma-exposed population is because it's there's a lot of reasons, but one is that it's very difficult for them to adjust to new people coming into the group every week. So when you're dealing with folks who've experienced a lot of trauma, who have a lot of difficulties trusting other people, it can take them some time to learn to connect with each other, to develop that positive group cohesion, the therapeutic relationship with a therapist. And bringing new people in again and again can be really difficult for them. It can really throw them off. I've had group members who've experienced severe trauma. I had one group member who was sexually assaulted by a group of men. So just him sitting there in the room with a group of men that he didn't know was very difficult for him. It was actually very triggering for him. So the idea of new men coming into the group every week would be very challenging for folks like him. Another reason why closed groups are important is because our group is really a cognitive behavioral group. So this is different than a lot of the programs that are out there that are more psychoeducational. Our group is not really just teaching a class, but it's really teaching specific skills that the group members kind of learn and build upon every week. So the material from one week leads into the material in the next week. So as I'll be talking about in a minute, first we go over basic psychoeducation about what abuse is, what trauma is, what are your core themes, all that kind of stuff. And then we talk about specific skills for recognizing their anger reactions, their aggressive reactions, learning to take timeouts, then moving into their survival mode ways of thinking, recognizing their negative thought patterns, trying to work with them and correcting those negative ways of thinking, and then working on more higher level skills such as identifying and expressing feelings and communication skills. So there's a lot of repetition throughout the course of the group, and one session builds to the next to the next. The group consists of 12 weekly 2-hour sessions. So many of you who do IPV work may recognize, or it may strike you how that's a pretty short group compared to what a lot of programs are in the community. And again, this is cognitive behavioral therapy. Treatment for PTSD, cognitive processing therapy for PTSD is also 12 weeks. Most cognitive behavioral therapies are not 20, 30, 40 weeks long like other kind of batterer program interventions. So when you're doing intense therapy, you don't necessarily need to do like 30 or 40 week groups, and there's actually no real evidence, no scientific evidence showing that longer groups are actually any more effective than shorter groups. There's about usually 5 to 8 individuals per group to start, and oftentimes at the end of the group there's a little bit fewer group members. They're often led by male and female co-therapist teams, just like most other batterer programs or IPV programs out there. And the idea is to model appropriate behavior among men and women in the group. And folks in our group also receive additional monitoring, treatment, and support. Dr. Stith also talked about the importance of a coordinated community system. We also think that's really important in doing trauma-informed work. We reach out to the partners of those who are doing our program. We've been really fortunate to have reached over 70% of partners who reach our program, which takes a lot of work. It's really hard to get partners on the phone. They often don't want anything to do with their partner anymore. They don't want to talk about it. They might have trauma or PTSD, so it's difficult for them to talk about it. But we really put a lot of resources into trying to reach out to the partners and connect with them, give them hotline numbers, give them resources for the abuse to help talk to them about abuse. Many of the partners we contact don't even necessarily recognize when they're experiencing psychological abuse. And often we're really the first contact they have who talks to them about partner violence, who talks to them about resources for partner violence. So that's really important. And we want to get their perspective on any abuse that may be going on as well. I touched a little bit on interventions that inform Strength of the Home. So interventions that inform Strength of the Home include PTSD interventions such as cognitive processing therapy, also couples therapy for PTSD, as well as other IPV programs that are out there. So we took what we thought were the most impactful elements from various streams of intervention, including IPV intervention, but also PTSD intervention. And again, our goal here isn't to treat the PTSD. And we're not saying that PTSD is the cause of the violence, but there are certain elements in PTSD treatment that I discussed a little bit earlier, such as the core themes underlying trauma, relationship problems, and PTSD that I think are highly relevant for this population. Another thing that we did that I think has made a big difference in our program is that we've made an effort to include a lot of repetition just over basic concepts. So I've worked in a lot of different programs in the community and in the VA over the years. And one thing that I've noticed in some programs is the programs that tend to be less impactful throw way too much at the client. Where they sort of take a kitchen sink approach, and they're like, well, we'll just throw this session in, then we'll throw this session, and you throw topic after topic, this and that, and then by the end of the program, you ask the group members, what did you get out of the program? What was most useful to you? And they just kind of stare at you blankly as if they didn't retain anything that you've been talking about over the past several weeks. So we really took great pains to include a lot of repetition and focus on a handful of what we thought were the most important, impactful concepts and interventions, and there's a lot of repetition from week to week, and like I said, we build upon the material from one session to the next. So there were a handful of what I think were really important concepts that it would be very difficult for a group member not to get it by the end of the program. So I mentioned that there's these different phases to the program. The first stage is psychoeducation. And here, right off the bat in the first session, we're using elements of motivational interviewing. So one of the interventions we do right off the bat is we talk about the pros and cons of aggressive behavior. When we introduce this, what we do is we ask group members, how do we learn to be aggressive in relationships? Or how do we learn to be abusive? And often the group members will say to us, well, we learn it because our parents were abusive to each other, or my parents were abusive to me, or I witness, we see it everywhere in the media, or in my neighborhood there's violence everywhere. We make the point that yes, we do learn to be aggressive or abusive in relationships from these experiences that we have, but we also learn to be aggressive in relationships because we actually get something from it. And it's really important to think about what is reinforcing our aggressive behavior in our relationships, because that is ultimately what is keeping that behavior going. If you weren't getting anything from it, you'd be much less likely to do it. So we ask the group members, and we write this on the board, a kind of benefits and costs of their abuse, or pros and cons of their abuse. We ask them, what do you actually get from it? And again, often our group members just kind of look at us blankly because nobody's ever asked them that question. Here we have group leaders asking them, what are the pros of you being abusive? What are you getting from it? And they're sort of afraid to answer because nowhere have they felt that open to talk about their abuse before. And that's kind of the point, is we want them to feel comfortable talking about their abuse. We want to show them right at the very beginning, this is a place you can talk about this stuff, and we're not going to jump down your throat. We're not going to punish you right away. This is the place where we talk about this, and this is how we work to end the abuse. So often they'll say a handful of things. Sometimes the power and control issues will come up here, and they'll say, well, I feel like it's the only way I can get in control of the situation, or it's the only way I can stop her from talking. It's the only way I feel more powerful in this situation. Sometimes they'll say, it's the only way I know how to relieve tension, and I get it off my chest, I yell at her, and then it's gone, and then I feel better. And so usually there's not very many pros or benefits that they talk about. There's only a handful of them. And then we ask them, what are the negative consequences of your abuse? And they give a long list, 20 or 30 things, and all the things that you can imagine. And if you're doing this work, you've probably heard them all before. Feeling guilty for the impacts on their partner, losing their relationship, negative impacts on their kids, being stigmatized as a batterer, losing a job, losing a military position, feeling guilt and shame. It just goes on and on, all of the negative consequences they've experienced from their abuse. Legal system issues, court costs, financial issues, being court ordered to do a batterer program. It goes on and on. So then we have this written on the board where there's a handful of things that they're getting from their aggression in their relationships, and there's all these negative consequences. And we ask the group members to kind of reflect on the board and what they're seeing. And what we're hoping to see there is sort of an aha moment around the room where group members are really recognizing that while they feel like they're getting something in the short term, they may not even recognize that they're getting something from it in the short term that's keeping that abuse going. It's really not working for them at all because it has all these negative long-term consequences. So the point that we make to the group members then is, we can help you meet the needs of these short-term benefits or pros in your relationship without all the negative consequences. In our trauma-informed program, we can help you feel more in control. We can help you end an argument, end a discussion without being aggressive, without all these negative consequences. Basically, we're going to help you do all of these things without all the negative consequences. So that's really just an intervention we do right off the bat to try to get them on board with the program. Because when folks are first starting our program, we assume that they're not motivated. We're not assuming that they're coming in ready to work on their abuse. We're not assuming they're coming in kind of saying, yeah, I'm an abuser, I'm a batterer, and I need help. Some of them feel that way, but many of them don't. And many of the folks who come in, as you all know, come in blaming the partner, blaming the victim, blaming the system, blaming everybody else, and not taking responsibility. So if we're going to jump right in and try to teach them skills right off the bat, we're not going to really be meeting them where they are in terms of their readiness for change. So our first step is to try to get them on board with the program, get them more ready for the program before we start to try to teach them specific skills. So we do the pros and cons of abuse. We talk about the different forms of abuse, not just physical abuse, but also the various forms of psychological abuse. We spend a good portion of this session talking about the different forms of psychological abuse. The more coercive, controlling, kind of domestic terror, intimate terrorism stuff, the more kind of domination, intimidation kinds of behaviors, the more hostile withdrawal, where a partner refuses to talk about something their partner thinks is important, or they just walk out and leave the house and don't come back for a day. The controlling behavior. So we talk about all the different forms of psychological abuse, and we encourage the group members to talk about which of these do you do? Which of these things can you relate to? Which of these are going on in your own relationship? And you'd be really surprised at how many of our group members readily identify with psychological abuse in particular. They'll own up to it, they'll talk about it in a really open way, which we think is another really important step for them taking responsibility of their abuse. We talk about the core themes that I've touched on a couple times already today, and we're really working with the group members to try to have them come up with their specific goals for a group. And again, it's going to be different for everybody in our group. Different themes may be differentially relevant for some group members than others. Then we do a lot of kind of cognitive behavioral skills training that you're probably familiar with if you do any kind of intervention like this, such as understanding the different components of anger, the thoughts and feelings and physiological components of anger. Assertiveness training is a key part of our program. Throughout every session, we talk about the importance of assertiveness, finding that middle ground between holding everything in, stuffing all your feelings, to going to the other extreme and blowing up. Because what often happens is our group members stuff their feelings, and eventually those feelings come out all at once and in an aggressive outburst. Most of the group members we work with have problems being assertive. Almost all of them have problems being assertive, and they fall in one of the extremes of being overly passive or overly aggressive, or both. And then we teach them timeouts to de-escalate situations. The next phase is coping strategies. Here's where we're talking about these kind of survival mode ways of thinking, negative interpretations of one's partners. We also do kind of stress management skills training here. And then we focus more on communication skills training. So heavy emphasis on learning to listen to one's partner better, heavy emphasis on identifying and expressing feelings. When we were first developing this program, we weren't really sure how our group was going to respond to all of our material on feelings. We thought that maybe they would think it's a little bit kind of hokey or flaky or whatever. And what we found is that our group members love that material on identifying and expressing their feelings. And by the time we get to the last session, we ask group members, what do you feel like you need to continue to work on? They'll very often work on identifying and expressing feelings as something that they found was really helpful in group and something they need to continue to work on in the future. Okay, so we've done randomized controlled trials. I'm just going to show you a little bit of the data. So this was a sample of 135 men. We published the study in the Journal of Clinical Psychiatry. Let me see. And I'm not going to go through how the randomization worked, but basically we compared people who were in the strength who we referred right to strength at home versus people who were what we called an enhanced treatment as usual condition. These were folks who may have been monitored by the courts. They were receiving anger management in the VA or other treatment for PTSD and other problems, just whatever standard VA care might be for problems related to anger and violence. So those are the two groups that we compared. This is probably the most informative graph that we have, that is just pretty straightforward, and it looks at the different rates of violence at each time point. And this is looking at physical violence, yes or no. Did that person engage in any physical violence during this specific time period, as reported by either the veteran or their partner on the revised conflict tactics scales? So at baseline, we found that just about everybody reported physical violence. And if they didn't report physical violence, then they had a court case documenting there was an act of physical violence. And then at post-treatment, we found pretty dramatic differences. In Strength at Home, we found that almost half of those in the Strength at Home condition had reported violence or engaged in violence compared to those in the enhanced treatment as usual condition. 23% versus 43%. And at 3-month follow-up, we found that the rates continued to go down in both groups, but they still remained lower in the Strength at Home condition. So this is looking at physical violence. And then we looked at psychological violence, and we also found significant differences between the groups in terms of their trajectories of psychological abuse. So greater reductions in psychological abuse in Strength at Home compared to enhanced treatment as usual. We found the differences were especially strong for what we called restrictive engulfment behaviors. So these are the more kind of intimate terrorism kind of behaviors, where one is checking up on their partner constantly, telling them where they can go, what they could do, telling them not to spend time with friends or family members, et cetera. So we felt really good to know that our program was especially impactful in reducing and ending these kinds of abusive behaviors. Okay, so next I want to talk a little bit about our implementation work. And I'm not going to spend a whole lot of time talking about this. This is very kind of veteran specific. But over the past 3 years, we've been fortunate to get funding from a few foundations in the community to implement Strength at Home across the VA healthcare system. And so far, we've implemented Strength at Home in about 30 different VAs. This is part of a larger programmatic effort on the part of the Department of Veterans Affairs to do partner violence work. So now there's IPV coordinators at each VA, or at least that's the goal, to institute IPV coordinators at each VA. And our goal is to implement Strength at Home at all of the VAs. So these are not all of the sites, but these are just some of the sites. We're not here in Utah yet. This is just the map. In red, the red dots are all the sites that we've trained so far. And we've looked a little bit at some of the data. We have found significant reductions in different forms of abuse in those who are coming into the program across the VA system. Another interesting finding is we're also finding that we're reducing PTSD symptoms. So these were statistically significant reductions in PTSD symptoms among those who are coming to the VA doing our Strength at Home program. Now, this was something that we didn't predict, we didn't hypothesize, because again, our program isn't a treatment for PTSD, but we do talk about the core themes relevant for PTSD. So it's not too surprising we're also seeing reductions in PTSD symptoms as well. Okay, so that's all I'm going to talk about for the data for our implementation program. So if any of you are affiliated with the VA and want Strength at Home in your VA, come talk to me afterwards and we can talk about that. So next I want to talk about our other program, the Strength at Home Couples Prevention Program. Yep. And this was a program that was funded by the Centers for Disease Control. The idea was to prevent violence in an at-risk population. And the at-risk population that we worked with were returning military veterans. So the idea, again, was to develop this model IPV prevention program to prevent the abuse before it begins. It's trauma-informed, based on the social information processing model. And currently, where this program is now, so we completed the randomized control trial. We published the results in the Journal of Consulting and Clinical Psychology. Now we're implementing this program through a grant through the Department of Defense at Madigan Army Base in Tacoma, Washington, Fort Lewis McChord. And we're also now implementing this program in the community as well. So this program, the different phases of the program are actually fairly comparable to the other Strength at Home program that I talked about. So I'm not going to go into a lot of detail. The first section focuses on psychoeducation, the next on conflict management, and the next on communication skills training. But here we're doing this with groups of couples. So these are couples who have not yet engaged in violence, physical violence. They may have engaged in psychological abuse or have or be unhappy in their relationship, but it hasn't escalated to physical violence. And what we found is by just having groups of couples in a room is incredibly powerful. especially with a military population, when you have service members or veterans, talking to other veterans and also hearing the perspective of the partners of other veterans, and you have partners hearing the perspective of other partners and other veterans, there's a lot of group cohesion, there's a lot of connection in the group, and this is a really powerful force for change. Throughout all of our groups, when we do training for all of these, we really emphasize process factors. We think the group cohesion, the therapeutic relationship, these are all really important ingredients for change across any treatment population, but I think especially when you're talking about a highly trauma-exposed population, they're really important. Okay, so I'm just going to present some of the data from this. This is a sample of 156 folks. We found much higher treatment completion in those who did Strength to Home compared to our other program that we compared it to, which was supportive therapy. Basically, we compared folks who were doing these Strength to Home groups to people who were doing couples support groups, where the couples were determining the agenda, and really they were doing the work instead of having the therapist create the agenda and kind of guide the work. So much higher completion rates among those in Strength to Home, almost twice as many completed Strength to Home as supportive therapy. So these are looking at rates of physical violence in the veterans. And again, we found strong differences, much lower rates of physical violence in Strength to Home in veterans compared to those in supportive therapy. We also found the partner's physical violence was much lower in Strength to Home compared to supportive therapy. Similar for psychological abuse, we found much lower rates in Strength to Home than supportive therapy. Same thing for partner psychological abuse, so you may be noticing a pattern, and all the rest of the slides are pretty much like this. Another measure of psychological abuse, the multidimensional measure of psychological abuse, we found lower or reductions on this measure of psychological abuse in Strength to Home compared to supportive therapy for veterans and also for partners. That's my last slide, so thank you.
Thank you so much, Dr. Taft. Boy, I don't know about you, but I'm also just overwhelmed with wanting to know more. And I hope you'll submit some questions that we can deal with in the panel this afternoon. I think we may have time for maybe 2 questions right now. Right there, Laura.
So preventative couple intervention, is that only for DOD?
That is only for DOD, right? So, and the idea behind that is, so we tested this first in the VA. When we did the study, it was at the VA. And we showed that it worked with the data that I showed. The reason we're doing it at DOD now is because we really want to get the couples as early as possible. So rather than wait till they come into the VA system where folks tend to be a little older, further out after deployment, we want to get them right there on the installation before they even come to the VA. So that's the idea. Ultimately, we want this to spread across DOD, across the military. We do want to do it at the VA as well, but that's just kind of how things have worked out so far.
Very quick follow-up, is that only in active duty military members or people who are in reserves or in Guard and deployed getting the same opportunity?
So, well, right now we're only doing it on one military installation, and we spent the last 2 years trying to get all the approvals to get started. So we haven't even actually started recruiting yet, but we do want to keep it as broad as we possibly can. So we certainly, when we did this study at the VA, it had Guard and reserves. That's mostly who we worked with. So that is our goal, to kind of be as expansive as possible, try to bring in as many people as we possibly can.
So unfortunately, we are out of time. I really feel that we're rushing things too much, but we need to keep on schedule. So we'll have another 15-minute break, and the next session will start at 11 o'clock sharp. Thank you.
Thank you.